everybody. Welcome back to the I Believe podcast. Thank you to our listeners and subscribers. Today, we are joined by one of the experts in ocular melanoma in the field, Dr. Carol Shields from Wills Eye Hospital. Dr. Shields, thank you so much for joining us today.
Yes, thank you for inviting me. I'm really looking forward to this session.
Dr. Shields, I know you are huge in the research field, so can you just tell us what are you currently focused on in the research field for ocular melanoma?
There's so much to think about when we talk about ocular melanoma, or maybe more specifically, uveal melanoma. Because when we say ocular melanoma, you never know if they're referring to conjunctival or uveal melanoma. But regarding uveal melanoma, I think one of the keys is early detection. I think that is so important because the earlier you catch the melanoma, the smaller the melanoma, the better the patient prognosis. And then the second important thing that we're really involved in is genetic testing. You know, genetic testing dates way back to Karen Sisley in England, who did genetic testing on 6 uveal melanomas and found that there were mutations in chromosomes 3, 6, and 8. And then hundreds of papers later, and 30 years, 40 years later, we're finding that, now we know there's 4 different types of uveal melanoma, and we can characterize them based on their genetics. Then the last topic about uveal melanoma, so these are 3 big topics. Number 1, early detection. Number 2, genetics. You really have to know the genetics of the tumor. And then number 3, what can we do to protect the patient systemically to prevent metastatic disease? And we have 2 new agents. We're testing one already, and we have another agent lined up ready to go for testing. And both are actually pretty favorable, so we're really excited about it.
So that sounds so exciting. I know one of the things we talk about at A Cure Inside is just trying to emphasize eye exams and how important having an annual eye exam is. But what are you guys finding?
You hit the nail on the head. That's the most important part. By the age of 40, the American Academy of Ophthalmology recommends that everyone gets an eye examination every year for a number of reasons. Number 1, to see if you have cataracts. Number 2, to see if you have glaucoma. Number 3, to make sure your retina's flat. Make sure you don't have edema. But also, very importantly, make sure you don't have like suspicious freckles or, a scar that could produce something bad, or maybe even a melanoma that you may be asymptomatic. So today I had a whole office filled with patients, and I bet most of the patients had melanoma, and maybe half of them, or maybe a third of them, presented with no symptoms. They walked in for a routine examination, and their doctor said, "Oh my gosh, your eyes look good, but I'm worried about that spot in your right eye." And so they send the patient to us. So I do think early detection starts with a good eye examination once a year.
So in your opinion, what makes up a good eye exam, if we were just to define that briefly?
Yeah, so the general ophthalmologist or the comprehensive ophthalmologist would first check for glasses, okay? How can that be a sign of you have a melanoma in the eye? Well, if they find that one eye has the lens pushed a certain way, then the refraction is going to be very difficult. And that would be for a ciliary body melanoma. And that's how some people are detected. And then to check the conjunctiva, upper and lower conjunctiva, because sometimes all the patient presents with is a large episcleral blood vessel. And then you look and you say, well, that's not right. And then you look in the eye and then you find the melanoma. Or, of course, if you see the patient has blurred vision and you can't correct it with glasses, well, then you got to look in the back of the eye and check to see what's the cause for the blurred vision. Maybe get a fundus photograph and get an OCT, these are tests, and get even an ultrasound to see if there's something solid in the back of the eye that's making the vision blurred. So there's a lot of things. There's actually a lot of things that the comprehensive ophthalmologist thinks about when a patient comes in with blurred vision. Our job is a little bit easier because most of the time when patients get sent to us, they're sent to us with a question like, is this a melanoma? Or could this be a nevus or a melanoma? Or can you check the eye to make sure there's no melanoma in the eye? So for example, today we had a lady come in who had a birthmark on her eye. This birthmark is called melanocytosis. It is well established that melanocytosis, which is a congenital birthmark that makes the eye turn brown and the blue iris turn brown. So she had light brown, dark brown iris. And we did a full examination on her front to back. She didn't have melanoma. 99% of patients with that birthmark don't get melanoma. But if they do get melanoma, it's a little more worrisome because it carries a higher rate of spread. So that's why patients who have congenital pigmentation on the eye should actually be in to see their eye doctor once or twice a year.
Well, thank you so much. I feel like that was such a good way to help us understand just really what goes on behind the scenes in an ophthalmology office when someone is having an eye exam. So our second area of research that you touched on was the genetics of the tumors and how that has kind of accelerated in the last 30 or so years. Do you want to talk a little bit more about that?
Sure. So it was back in the 1990s when a few researchers from England and from Germany realized that uveal melanoma carries a mutation in chromosome 3. And then they realized, oh, it's chromosome 3, 6, and 8. And many of us have explored that. And now we can use chromosomal mutations to help us prognosticate if a patient's going to do well or not so well systemically. So we now have what's called the Cancer Genome Atlas, which is, remember years ago, they did the human genome at the National Institute of Health took many samples from many different people and they created the human genome. So we know what is normal and what is abnormal in humans. And then they went on to do the Cancer Genome Atlas, the same group, National Institute of Health, and found that uveal melanoma has mutations in chromosomes 3, 6, and 8. They confirmed that. And then they constructed the good mutations from the bad mutations. And good mutations would be no mutation at all in chromosome 3, 6, or 8, or maybe a little half mutation in chromosome 8. Those two mutations are A or B, and they correlate with good prognosis, like low risk for metastatic disease, whereas C and D are at higher risk for mutations, and they have mutations in chromosomes 3 plus chromosome 8 and multiple mutations in chromosome 8, and they're at greater risk for metastatic disease. So now we do genetic testing on everyone. We offer it to everybody. And how do we do it? Well, we take a sample from the tumor using fine needle aspiration biopsy. So I'm using my hand with my lens. I have my lens in one hand. In my left hand, let me see if I can get it in, and I put the needle into the eye, into the tumor, under my indirect watching, take a little sample of 20 cells, send it to the genetics team, and they tell us what that tumor mutation profile is. So we know from that test at the time of their radiation, that tells us if they're at low risk or high risk for mutation, for metastatic disease based on mutations. And this has been, I think, revolutionary in our ability to identify patients at risk and maybe in some cases reduce their risk. So we started out years ago by trying to reduce the risk using a medication for high risk people, those that have mutations in chromosome 3 and multiple mutations in 8. We call them the Cancer Genome Atlas group C and D. What we do in those patients is we put them on sunitinib, which is a medication that has been shown to reduce their risk for metastatic disease. Now we're putting them on a medication called darovasertib, or Daro for short. And there are several centers now in the US who are doing this. Very interesting. We're doing it in two different ways. First, we're using Daro. This takes me into the new medication section of uveal melanoma. We're using Daro as a neoadjuvant. That means before we even treat the melanoma, we give them 2 to 6 months of Daro, see how they're doing. We check them at 2 months to make sure the tumor in the eye is shrinking, and in hopes that this might prevent metastatic disease. So we monitor them every 2 months, and they get up to 6 months of Daro. Then we put the plaque on the eye. Now, why do we wait? Well, because Daro takes a melanoma and shrinks it and shrinks it. I've seen it shrink melanoma 80% of the thickness. So you're left with just a little thin tumor. So when you put the radiation on the eye, you get very little dose to the center of vision. So our hope is we can reduce the dose of radiation to the eye and protect more vision for each patient.
That's
But our
absolutely
ultimate,
amazing.
our big hope is that we reduce the risk for metastatic disease. Imagine if in the eye it's shrinking the tumor down, what it might be doing to the rest of the body. It might be getting rid of the cancer in the liver or wherever else it wants to grow, because Darrow is not just focused on the eye, it goes everywhere in the body. We're very excited about this. So we use it as neoadjuvant before we do the radiation to the eye, and then we continue it as an adjuvant treatment. Even after we do the radiation, we continue it 6 to 12 months. They're not real sure how long they want us to continue it, but I think we might continue it up to 1 year if the patient tolerates it. And then we're going to have answers in a year or two. If we see that patients who get neoadjuvant or adjuvant Darrow have fewer events of metastatic disease, well, then it's going to become a routine treatment.
That's
We
absolutely
never
incredible.
had a routine treatment like that. We only treated the eye, and then we prayed that the patient wouldn't get metastatic disease. Now we may actually have a very scientifically sound way to prevent metastatic disease.
It sounds like that's absolutely one of the most exciting things about the
It is.
research that you guys are focused on.
We're so excited. And this is not just us doing this. This involves like multiple sites in the US. And I know in Europe, they're chomping at the bit to get started. They want to get started with this because most of the uveal melanomas in the world on planet Earth occur in North America and in Europe, where you see fair-skinned people, the Canadians, the Americans, and mostly Northern Europeans, the very blonde Scandinavians, people from the Netherlands, but also people from France and Spain and, Turkey and Italy. Yeah.
So in terms of these people collaborating at all of these different centers, how do you see the collaboration helping to accelerate this specific research for this adjuvant and neoadjuvant treatment?
So we're going to get large numbers of patients. It's not hard to enroll a patient on this trial because patients, when they understand that our ultimate goal is to protect them from metastatic disease, okay, I can put up with the nausea, I can put up with the diarrhea or the vomiting that might occur with this medication when they understand what the ultimate goal is. So I think we are going to have large numbers enrolled, and we will get to the bottom of this probably within a year or two. We will see A, how fast the tumor in the eye shrinks, B, that we're going to have hopefully reduced radiation dose to the eye, and then C, normally by about 3 years to 5 years, we'll have information on metastatic risk. But we'll get a lot of information right off the bat. So we have our colleagues in Australia to thank for this, because they were the first to really witness that this medication was effective for not only the eye melanoma, but for systemically. And they've already done a preliminary study called NADOM, Neoadjuvant Darovasertib for Ocular Melanoma, NADOM. And they presented their data at the American Society of Clinical Oncology just like a month ago. And I think there was a lot of enthusiasm worldwide about their preliminary results. They showed, about 15% reduction in the eye, but all this was very preliminary. Not much to say about long-term Mets, but we're seeing evidence that it's shrinking tumors in the eye. Yeah, we're taking a disease that used to be 40%, 50% deadly, and we're actually morphing it into, we think, a less serious condition that we're more able to change by upfront chemotherapy.
Yeah, that's so powerful.
Yeah.
Well, I am so thrilled for all of this. And the research landscape is obviously something that I'm sure we could talk on for hours. But I really want to also ask you a couple questions about some of the things you've developed as resources for ocular oncologists. Specifically, and I'm hoping I'm not going to mess this up, the mnemonic scale that you have, or this resource that is TFSOM-UHHD. So can you just explain what this is and what you were trying to achieve when you developed this resource?
Right. So back in the 1990s, well, when I started in the field of ocular oncology back in the 1980s, 1984, we would look at a choroidal nevus and we would say suspicious, non-suspicious. We had no criteria. Like, how did we know it was suspicious? Well, maybe it had fluid, but we just had no criteria. So I said, this is sort of a guessing game. I said, let's gather all the clinical data we can on choroidal nevi and follow them for 5 years and see what clinical feature predicts growth into melanoma. So we did that in 1997 and published it. Then we did on 1,600 patients. Then in 2009, we did it on a completely new cohort all over again on 2,500 patients. Then in 2019, we did it all over again on a new cohort of over 3,000 patients. Because we see choroidal nevi so commonly in our office, we can identify clinical features. And the clinical features with the first study in 1997 were just clinical features. And then for the second study, mostly clinical features. But for the third study in 2019, they were all imaging features. Now, I trust my imaging more than I trust my doctors saying, oh, I think there's orange pigment. Oh, I think there's subretinal fluid. I say to them, prove it to me. So to find orange pigment, you have to do autofluorescence. And to find subretinal fluid, you have to do autofluorescence or OCT. So we now have imaging features we have clinical risk factors based on imaging features, which imaging features tell you the truth. It doesn't estimate or guess. It says, yes, there's fluid or no, there's fluid. So now we have a mnemonic. It's called TFSOM-DIM, D-I-M. That's the most recent mnemonic. TFSOM hasn't changed much over the past several decades. So we hit the nail on the head when we had the original mnemonic was TFSOM. The T stands for thickness over 2 millimeters. Yes, it's still a risk factor. It's always been a risk factor. The F is fluid, always been a risk factor. The S used to be symptoms. Now it's symptoms of vision loss. The O is orange pigment, always been a risk factor. And the M now stands for melanoma hollow on ultrasound. That's a new one. And the DIM, D-I-M, stands for diameter greater than 5 millimeters. So these are all based on imaging. T, thickness over 2 millimeters. F, fluid. S, symptoms of vision loss 20/50 or worse. O, orange pigment. M, melanoma hollow on ultrasound. And DIM, diameter greater than 5 millimeters. So 2 of these risk factors depends on ultrasound. The first one, thickness, and the 5th one, melanoma hollow. One depends on OCT, fluid. One depends on vision, Snellen vision, symptoms of vision loss. One depends on autofluorescence, orange pigment. And then the DIM depends on fundus photography. So we do all that imaging on every nevus that we see in our office. We get it done real fast. And then we sit down with the patient and we say, hey, you have no risk factors. That means you have less than 1% chance that that lesion in your eye will ever turn into melanoma. Patients are so happy. Or we say, hey, you have one risk factor. Any one risk factor creates an 11% risk that tumor, that lesion might grow into a melanoma within 5 years. Any 3 risk factors, 34% chance. So it's 1 out of 3. So if you have 3 risk factors, you have a 1/3 chance that within 5 years, you're going to have a melanoma originating from that tumor. If you have any 4 risk factors, these are powerful risk factors. You have a greater than 50% chance that that nevus in your eye is going to turn into melanoma. Now, most people have 0 or 1 risk factor. So most people, we can say, yeah, it's not going to happen. But those that have, say, 3 or more risk factors, we're checking them every 4 to 6 months, or we just treat them. We say, if you have 4 risk factors and you have thickness over 2 millimeters and fluid and orange pigment and it's hollow on ultrasound, we would say, hey, that's a melanoma waiting to be identified. We'd say, hey, get treatment today. You don't need to wait on this. It's going to turn into melanoma, because that ultrasound hollowness, that dates back to, I'll never forget, Culver Bolt, Dr. Bolt from Iowa. This guy's a smart guy. He's also a good tennis player, but he's spent his whole career at Iowa, which is a great center for ocular oncology. And many years ago, back in the 1990s, he wrote a paper that said, acoustic hollowness on ultrasound really matters. And we couldn't get it into our mnemonic. It never made the cutoff for risk factors until we did only imaging. And acoustic hollowness made the cutoff. Anyone who has acoustic hollowness, it's about a 3 times greater risk, hazard ratio, we say, for the development of melanoma. So you got to look at your OCT, you got to look at your autofluorescence, and you got to look at your ultrasound. This is so important. Just this morning, we host a monthly, we call it Shields Ocular Oncology Rounds. It's a Zoom meeting, mostly for doctors, but people can listen in. It's a Zoom meeting, and we had doctors from all over. We had them from Italy, from Turkey, from India, from Ecuador, from Chile, you name it. They were from everywhere, from the Netherlands. And we showed a case where the patient had one tumor, but when you got autofluorescence, he had 3 different tumors in the back of his eye. All 3 of them we had to treat. So he had a condition called melanocytosis, which can promote multiple tumors. So everything made sense. But these imaging modalities are really important in our assessment. And that mnemonic, if we can use that mnemonic on every patient with a nevus, we would probably find 90% of choroidal melanomas early on.
I feel like that's such a powerful tool that hopefully, any ocular oncologists, any ophthalmologists who might listen to this, or just people who can share this with your ophthalmology offices. I know there's a kind of a dime a dozen, right? There's so many ophthalmologists around, but if we were able to get this in the hands of all of those ophthalmologists who come across the nevus first before they ever even send them to someone like you, that would be pivotal in the early detection area.
It would be a game changer. If everyone used these risk factors and said, oh, this patient has 3 of 6 risk factors. I mean, it's to the point that we actually, with our second mnemonic, we put it online. We did a risk calculator for the second mnemonic. We should probably do it with this mnemonic. It was just published in, a few years ago, but we should put a risk calculator online so that when you type in, it automatically calculates the exact risk. Because we did a paper that we published in British Journal of Ophthalmology with Lauren Dalvin, who's the chief of ocular oncology at Mayo Clinic. She is such a smart kid. And what we did was we took all 62 iterations of combinations of 2 risk factors, 3 risk factors, 4, 5, 6 risk factors, and we calculated out the risk for transformation into melanoma. So what we should do is put a calculator online so patients can say, wow, I have these 3 risk factors. My risk is 42% chance by 5 years. Yeah, we can do that. That would be something really good to do. I can get one of our med students to do that. Got to find a smart one to do that.
Well, I love it. This is so unique, and I actually wasn't aware of this mnemonic.
It was published in the journal Retina. So it reached all the people it needs to reach, retina specialists. And this mnemonic is so important. It actually made the American Academy of Ophthalmology board test that every young resident must take. They said, here is a picture. Tell me what risk factors you see. So it made the board exams. So that tells me the American Academy of Ophthalmology is taking it seriously.
Oh, that's so cool.
If we could all use risk factors, I think we could shrink the population of patients who get melanoma. And there's a new drug that we're testing. It's called Belsar, belzuticap certalican. Not yet FDA approved, but we're testing it for small melanoma. Because if we could discover a patient who has 3 or more risk factors, we could treat them with Belsar. Belsar doesn't take your vision. It zaps the melanoma and it doesn't take your vision. Imagine a world where we had that. It's surreal. We just have to get the FDA to approve it.
Yes, which we know, at least here, just in talking with Aura and talking with some of the doctors like yourself who are helping with this trial, it involves patients enrolling. So making sure that we find those people, but also making sure that they're enrolling or getting enrolled with the trial at the right time.
Yeah.
So I really am so hopeful for this trial to get to approval, for the drug to get to approval, because I think what you said is absolutely right, that it will change the future of ocular melanoma.
Yeah. So no longer will it be a curse that you have a melanoma. oh, you're going to be at risk for metastasis. And by the way, our treatment's going to make you blind. No. If we can use risk factors, catch them early, zap them with Belsar, and put them on darovasertib, we may be able to save the majority of patients with melanoma. We have to work out all of these different variables, but we're working on it.
Yeah, absolutely. So with regards to different treatments, we've touched on a couple, right? You touched on the neoadjuvant with the Daro drug that is the IDEA trial, which there's multiple arms of that. You also touched on the Belsar drug and the Aura trial, the Compass trial. How have you seen the treatment landscape change over time, maybe specifically in the last 5 to 10 years?
Yeah, so since we are, we have FDA approval for Kimtrac, which is an immunotherapy to tebentafusp, but that's only approved for use for liver metastasis, for metastatic disease. We're doing this trial to get it approved for neoadjuvant and adjuvant. Belsar not yet approved. So the fact that, we can't be using any of these in a neoadjuvant or adjuvant setting at this point makes us still use our standard of therapy, which is plaque radiation. My hope is the next 5 years, as we get Daro hopefully approved for neoadjuvant and adjuvant, we'll see less heavy duty plaque radiation, more refined plaque radiation, and we might get permission to use Belsar in kind of a sympathetic way. If we shrink a tumor enough, we could just zap it with Belsar. I mean, I'm a believer in the medication. It's so scientifically sound. See, Belsar is based on the fact that this medication, viral conjugate, human papillomavirus conjugate, is attracted to cancer cells because cancer cells have heparin sulfate outside on the wall of the cells. And so this medication goes right into the cancer cell. And it has a little tag of a dye that when we shine the laser light onto it, it causes it to immediately cook, and it cooks the cancer cells. And at the same time, it sends out kind of denatured cancer cells that stimulates the immune system. So it works in two ways. It causes immediate necrosis, but it also causes a little immune boost to the body. And this is like amazing. I mean, the doctor who was really involved with the development of this drug, John Schilling, he's the inventor of the HPV vaccine. That vaccine, which is given to teenage kids, has pretty much cured cervical papillomas and has already, we've seen a reduction in cervical cancers because of one doctor, one vaccine. So I think he's really onto something big. And I am excited about its use for uveal melanoma, small tumors, and the other uses which we might be using it for in ocular oncology.
I think that's it's so neat to hear you kind of like speculate or hypothesize what could be possible, and just the creativity and like the engineering behind the scenes that goes on in your brain as you're thinking about all of the things that could come together because of where the future is headed. And it's so exciting to listen to.
Yeah, it's kind of like a perfect storm. Hey, if we can shrink a tumor with Daro and then maybe put a little plaque or zap it with Aura and keep them on Daro, we might be able to cure this problem.
No, that's insane. It's the coolest kind of insane, but it is so cool to listen to.
Because my 40 years in practice have been a little bit troublesome because I've always wanted to provide a better outcome for uveal melanoma patients. And hence, that's why we did risk factors, so we could detect them earlier, which was all we had available. And it works. It's on the front end of melanoma. And if we can all learn how to detect it better, that will help us on the front end. And Daro maybe more in the middle or in the back end. Yeah.
Oh, it's so unique. So we talked a little bit about biopsies, and I know you kind of showed us the visual of how you do that biopsy, but how have you seen the biopsies change the trajectory of patient treatment and care over time?
Big time, big time. So back in the day, we were one of the few teams to do fine needle aspiration biopsies. So much so that we wrote papers like in the 1990s on how to do FNABs. We actually started out with, believe it or not, a needle that you would put into an LP. Yee, that's a big needle to be putting in the eye. We've refined it. We use very tiny little needles. So for the front of the eye, we use 30 gauge needles. It's like a self-sealing wound. And for the back of the eye, we use 27 gauge needle. We've perfected this to the point that we can get needle biopsies with very little complication. So most patients will get a little dab of blood right at the site where we enter the tumor, and that's normal. And that by the time we see them 4 months later, it's gone. And very rarely do we ever see a regmatogenous retinal detachment. That was always our big worry. Are we going to create retinal detachment? And the answer is no. And of course, we don't see tumor recurrence along the needle biopsy track. I know of one case in our practice, and that's with over 5,000 FNABs. One had recurrence, and it was a patient who had a necrotic tumor, and a lot of the tumor had seeded. So either it was along the track or maybe it's seeded, but we don't know. But anyways, we took responsibility for that. But it didn't create like any bigger risk for the patient.
Well, 1 in 5,000 is pretty darn good.
Yeah. So now I would say most ocular oncologists are comfortable doing needle biopsies. They do them by one of many different methods. Some of those that are retina trained will do it using a pars plana vitrectomy. We, as ocular oncologists, just do a needle. We don't do a vitrectomy. We do nothing. We just put the needle through the pars plana, through the vitreous, into the tumor apex, aspirate cells, and then pull it out. Very little complication.
So as you do these biopsies, is the biopsy something that ever happens before treatment for you, or does it usually happen in the midst of treatment, like when you're doing brachytherapy?
So we usually do the biopsies before treatment. We do it for one of two reasons. Number one, if we need to have cytology. For example, if we don't know if it's a metastasis or a melanoma or a lymphoma, we'll do a biopsy. So that's before treatment. And the second reason we do it is we do it before treatment to assess genetics. So that's how we get genetics on really every patient. And we want to do it before treatment because once you irradiate a tumor, then you don't know if the mutations are related to your radiotherapy. So most people feel you should do it before you put radiation on the eye.
Is it typically done in the same procedure, or is it separate procedures?
We always try to bunch everything together so it's less trauma for the patient. So we usually do our fine needle aspiration biopsies. When we use it to differentiate melanoma from metastasis from lymphoma, we do it before treatment because those results tell us how to treat the patient. Yeah. But if we're doing it for cytogenetics, we'll do it at the time of treatment. So we do it right before we sew the plaque down. So we get everything prepared. We get all of our sutures in, ready to put the plaque down, and then we do fine needle aspiration biopsy. Why do we wait to do it at the last minute before we put the plaque down? Because when we go in to do fine needle aspiration biopsy, sometimes it softens the eye and it makes it harder to put in your scleral sutures to sew the plaque down on the eye. So that's why we like to get everything done regarding the plaque. Then we do needle biopsy for the melanoma, and then we sew the plaque down, but our sutures are already in the sclera.
I feel like that's so cool. I had no idea that any of this kind of went on behind the scenes. This is so neat.
So we think about these things as we do these procedures because we want to make our surgery as accurate and successful as possible without making it too hard for us to do, right? So we kind of think about it step by step. Yeah. And then, we put the plaque on the eye. The plaque typically stays on for about 4 days. If it's a big tumor, it might stay on for 7 days. See, we have a really good radiation oncology team who designs our plaques. So they design our plaques to all go on Thursday, and they design them such that every melanoma gets 70 gray to the apex, and all the plaques come off on Monday afternoon. Can you believe that? Back in the day, before we had this really good radiation design, we used to put plaques on Thursday, and then they'd come off Saturday at 1 p.m., Sunday at 2 a.m., Sunday at 3 p.m., Sunday at 7 p.m. Oh my God. I was running to and from the hospital constantly taking off plaques. Then I asked them, I said, hey, can you design these plaques based on tumor thickness to go on at one time and to all come off at the same time? They said, yes, we can do that. So now they all go on right at the same time on Thursday and, within 2 hours, and they all come off on Monday afternoon.
Wow.
So no one comes in middle of the night.
That's definitely got to be nice for you to not have to come in the middle of the night anymore.
Oh
Thank
my
goodness.
God. Yeah.
Well, Dr. Shields, this has been absolutely incredible to listen to you. Is there anything you'd like to say to our listeners just to wrap up what we just covered from, the research, the treatment landscape, the biopsies, some of these new trials?
So, as from a patient perspective, I think patients owe it to themselves to get an eye checkup once a year, to make sure you're dilated once a year, to have the front and the back of the eye checked. And from a doctor perspective, just remember the risk factors. So when you look at a nevus, you can be scientific about how you're going to judge that nevus. And know that there are a lot of new things going on in the field of ocular oncology, multiple new treatments, and the landscape for therapy in ocular oncology in the next few years is probably going to change for the better. So I'm really excited. Thank you.
Well, Dr. Shields, we're so excited that we got to have you on today. And if you guys want to tune in again, you're going to get to hear back in the future from Dr. Shields on pediatric ocular oncology, as well as pregnancy and ocular melanoma. So stay tuned. We'll be back next time.